Welcome to Vein and Lymphatic University. It is my pleasure to share today the talk that Professor Luca Palumbi is going to be talking about in terms of preliminary results for the TOTEM trial, Total Endovenous Laser Ablation. So on behalf of VLU and the executive board, thank you very much, and the floor is yours, Luca.
Thank you so much, Prof. It's always an honor to share with you symposium and webinar, and with in a lymphatic university too. So thank you again. Could you see my
Yes.
screen?
Perfect.
Yes, perfectly.
Thank you so much. So in 2026, in this moment, we have really a lot of choice to make every day about the type of device to use. We are now at the third generation of laser, third generation of RFA, also with new catheter in length and also in diameter, but also on non-two-machine, non-thermal technique. In this moment, we really have a lot of devices available about mechanical-chemical occlusion, rotational, non-rotational, catered based on the use of a catheter that empty the vein. We have different type of glue to use in this moment, and also regarding the foam sclerotherapy, we have we can now add to the component, physician component foam, some devices to make standardized and better foam. So really, we have a lot of devices to help us on treat the patient in the best way we can. But anything about the technique? That's a good question. And the answer is yes. In the last years, we are now we can now choose to treat our patient with total endovenous laser ablation concept. That means treat not just truncal vein with thermal, but use the third generational laser, especially if it's better for that, in my opinion, to treat simultaneously side branches and perforator vein. Perforator vein when they are incompetent, of course. So hemodynamics is still today our guidance, or should be for everyone. But first question that I probably would receive from the floor, and I would try to anticipate some of this, would be, do we really have to treat tributary varicose veins? Well, the answer is not mine. It comes from the literature. For example, this systematic review, it's really interesting, on about 7,000 limbs. They compare staged treatment to concomitant treatment. And what was, and at the conclusion of this really well done systematic review, was that basically patients that were treated with concomitant phlebectomies, foam, or treatment of the tributaries showed significantly lower risk of reintervention and a better venous clinical severity score. At the same time, there was not possible to observe more complication in this group. So basically, same risk with better outcome. And okay, you don't like this study? Let's go to the guidelines that we have in this moment. So if a patient refers to your office with GSV or SSV insufficiency, with varicose veins associated to this insufficiency, and the patient is symptomatic, the guidelines is telling us, treat, of course, the GSV or the SSV, basically the main trunk, and we suggest you to use thermal, and then you could consider to treat also the collateral varicose veins with foam or phlebectomies. And you could tell me, okay, but with low grade of recommendation and evidence, class 2A/B. But I would answer to this, yes, but it's exactly the same grade of recommendation of treat this patient with non-thermal. So I think that something that we should consider when we decide what to do. And let's try also to change a little bit perspective And if we are we just consider the patient point of view, we have another consideration to make. First, there is there are some studies, but I think this is really well done by a Sweden colleague, Blomgren, that show how residual incompetent tributaries after varicose vein surgery increase the need for intervention in a significant way. And it is comparable as leaving trunk vein untreated. And again, if we go on the literature, and we already in 2010, Professor Alun Davis with Prof. Gandhi told us that comparing, asking the patient about the satisfaction of the treatment, the main point about dissatisfaction of the patient were in those cases in which they had to have a second treatment for recurrent varicose vein. So another thing to consider. But now let's go to the topic, because time is running and I don't want to be boring. So to answer this question, which are the most one that we all receive about total endovenous ablation, which laser wavelength, how many needles do we have to use? It takes time. We don't have a standard protocol. We have a lot of risk of skin burns and etc. And it's not possible or not safe to treat no eVLED zone, and it is painful. For this reason, we decided to start our trial, TOTEM Trial, Total Endovenous Laser Ablation Multicenter Trial, with two colleagues that are connected and they are here tonight, Professor Linas Velicka and Professor Jan Szczepanski from Lithuania and Poland. And every center had to roll 50 patients in a study design that was multi-center, prospective, non-randomized, non-blind clinical trial. And in order to reduce some possible bias, we decided to adopt the same laser wavelength and the same fiber. So the endpoints of the trial were efficacy endpoint, occlusion for the primary efficacy endpoint, of course, the occlusion rate. For the secondary efficacy endpoint, what we need to standardize the procedure. So the parameters, the technical parameters that we were using during the procedure. So in terms of power watt and lead. And for the safety endpoints, of course, the incidence of complication and also especially the pain evaluation. And for the secondary safety endpoints, of course, the improvement on the disease. So in this moment, we have available some new results from also not just from my center in Venice, but also from the center led by Professor Velicka of Lithuania. And what we have in my center, we are now going to the 12 months follow-up. But until now, we completed 6 months follow-up, and we had 100% occlusion rate. We're talking about thermal 6 months, so I think it is something to expect. And regarding the other center, again, at 1 month follow-up, we had 100% occlusion rate. But for the secondary efficacy endpoints, we found some difference in the two centers. In my center, we delivered a lead of 43 joule per centimeters for the truncal ablation and 23 for the tributary ablation. Instead, in the other center, 53, basically 54 joule per centimeter for the truncal ablation and 33 for the tributary ablation. I do remember, everyone, that we are talking about third generation of laser. Regarding the primary safety endpoints, what was really interesting and probably a good thing to know in this moment is that the pain perception were really low in both centers. So from the patient point of view, it's really a procedure that it's well tolerated. In both centers, we had no major complication, so no e-thrombosis, no DVT, no bleeding. And we had, in my center, 1 case of superficial vein thrombosis, 1 case of pigmentation, so 2%, and 1 case of late paresthesia that appeared not at the first consultation, post-operative consultation, but after 3 months, with a complete regression at 6 months in this moment. And regarding the other center, no superficial vein thrombosis, no paresthesia, but more cases of hyperpigmentation, 10%. This is the case of my center of hyperpigmentation with a complete resolution after 3 months. Regarding the secondary safety endpoints, so quality of life, we evaluated with the revised venous clinical severity score. In both centers, we basically observed a halved RVCSS score. So well tolerated and a good improvement in the quality of life of our patient. But now the disclosure, nothing fixed for all. That's what I think. Of course, I do love total endovenous laser ablation concept, but not all cases are, in my opinion, good for this technique. And that's the reason why in my center, from 2018 to 2025, we have done almost 4,000 cases of treatment for varicose veins, main treatment. And of this, more than 2,600 were thermal, but we also performed mechanical chemical ablation, almost 1,000 cases, and more than 300 cases of glue occlusion. So going to the conclusion, I think that the advantage of this technique is that it's one-step procedure. The occlusion rate is similar to thermal, so in my opinion, it's really high and good, probably the best. We have a lot of advantage in terms of invasiveness of the procedure, and also in terms of the necessity of long-term compression, which is a really summer-friendly procedure, especially in my country, in which the summer is hot. And in terms of aesthetic result, what was possible to observe for me in my experience, that is, of course, more than 50 cases of TIVLA, the results are really comparable to mini phlebectomies or foam. I really thank you very much for the kind attention, and I would like, if I have the chance, to invite all of you to come and join us, especially also Professor Kapnik, which is part of the executive board, to our international meeting that will be in April. So still time to book your flight and come and join a good session with friends. Thank you so much.
Thank you very much, Luca. I have a zillion questions, but before, and so there are other questions on the chat group. But before we do that, I'm going to turn it over to our other trialists, and I'm going to start with Linas Velicka. Would you take over and your comments or questions?
The mic is it's off.
Thank you. Dear colleagues, thank you, and I am really glad to see you, and thank you, Lovell and Victor, for inviting to this session. For me, it's those results which they were shown. Probably some differences in our results we have, because we have different patients, and probably when we will see the all data from all three centers, we will have the full picture of this technology. But what I can see that it's really helpful, and for me it's like Luca showed that he has different techniques in his armamentarium. So for me, this total LVLT is the basic technique, and honestly, it pushed away mini phlebectomy almost completely from my practice. And with this results, I'm happy, and the patients, they are happy, and probably for me, what I see from my patients, and I will be glad to get some advices how to deal with this. It's a little bit more pain because I always perform this operation without only on local and without any premedication. This probably this multiple punctures, they require additional patients from our patients. So it's, for me, it's the only drawback, but the rest is, yes, it's much better because we don't need so much compression, we don't need dressings, we don't need the patient, they feel themselves healthier much earlier.
Well, thank you very much. Of course, you've opened up a whole bunch of more questions that I have. I'm going to ask one. In terms of your trial, would it be beneficial to have the same linear energy equivalent dosing so that there's no difference between centers? That's one consideration. And then any one of you can answer that. And two, when you're doing truncal ablation, are you using a 400 micron fiber too with the infinite fiber, which not necessarily has been vetted yet? Please respond.
Yes, I think that of course you always touch the point, but regarding the mean lead that we were delivering, of course we have to consider that this is the first trial. We don't have something to follow. So basically we're now creating something to, this is the phase 1 of the trial. We would like to, at the end of this, start with the phase 2, in which we will, of course, and you know that, involve also you, and more center as possible. But of course, in the phase 2, we will probably have more technical data to understand better which kind of protocol to follow, and then finally see if with the uniformity of protocols, the results could be different or not. So that's my answer to your first question. And the second one, yes, we do use only the 400 microns. And a little spoiler, for vein in Venice, we will present a new fiber, but I don't want to tell anything else about that because I would like to make spicy the thing in 2 months.
Fair enough. Thank you, Linas, and thank you, Luca, for that. Jan, the floor is yours.
What can I say? Previously, at the beginning of this, of even an idea of total EVLA, I was totally against. Luca knows that. Totally against the total EVLA even idea. I couldn't imagine even that I can do like this, and I decided to start once a day. And when I noticed the outcome just after 1 week, I decided to do it for everyday practice. And now I can say that we do only total EVLA. I even forget how to do phlebectomy. We do this kind of surgery only for the NHS. And normally we do just total EVLA, and I can say that there is no case, I mean, patient with the varicoses, which we can't do without using total EVLA. I mean, total EVLA is for in our practice is almost for everything, and from our experience, when reflux sources are treated completely in one session, recurrence becomes much more a strategy problem than a technology problem in the moment.
Thank you. I do have a question. Actually, it's from Professor Bashira. I know that Linas mentioned that he uses straight local anesthesia or tumescent anesthesia. What kind of anesthesia do you use? And the same with Luca. Do you use general? Do you use?
Do I start? Yes. Plain solution, but without adrenaline. I don't like to use adrenaline in the tumescent solution. Should be we use cold saline, as probably we all do. But a plain solution without adrenaline. That's what I do, and I think that tumescent anesthesia is the real key of the treatment. And again, if we empty the vein, whatever you do in the vein fits better. Also, if you do foam, if the vein is empty in any way, Trendelenburg, whatever you do in your practice, I think that you are more effective. And tumescent, it's a super great tool to use also for other technique.
So as you know, we've been in the United States, that's the majority of what we do. Majority is done in our office, and that's what I'm thinking that I'm hearing from you. No sedation, no IV. There is a question from Dr. Antonova, who wanted to thank the people that were talking. Have you considered also time to achieving the final goal? Could it be added as to the end point? So in other words, your time of the procedure. We also understand that there's another question with regard to that from Professor Hingarani in terms of how much time does it add? And I guess that's relative to the number of tributaries that you're treating, but an average.
My answer is that the same amount of time that used to do phlebectomies for that case, no more.
And then from me, the question is cost effectiveness, because you need a fair amount of equipment, angiocasts, et cetera, can you use one laser fiber for 25 tributaries?
Yes, the answer is yes. You can use this. We always use the same laser fiber. Of course, thermal. The cost of thermal it's higher than foam, or of course. But if we compare to standard treatment, I think that the cost it's not that much. You just need some cannulas, and we also, in some cases in which I want to reduce the number of puncture, I'm using in this moment a dedicated catheter, which is a 4 French sheet catheter with a guide wire, so I can navigate some big varicosity. And so with one puncture, normally I try to treat all that collateral varicose veins in order to reduce the invasiveness. And as Linas said, the puncture it's the painful part of the treatment. So if I can reduce it, it's okay. Of course, this catheter has a cost, but it's not mandatory. It's what I do in my practice, but you can avoid it.
So it doesn't look like the porcupine procedure. So you're putting in a needle, a wire, a sheath. Linas and Jan, do you do the same?
I'm doing only with cannulas, and so I'm using cannulas 14 or 16 G, and usually those cannulas, the best for me, it's B Brown. So B Brown is two types with some fixation wings, and intracan which have no wings. So those intracan cannulas also having the safety feature that you cannot injure yourself with locking of sharp angle. So this is a little bit more expensive. So in our country, it costs like B Brown cannula usual costs less than €1. And cannula with intracan is probably 30% more. So if we use very complicated and complex case, for me it was in trial it was 33 punctures. So you can count how much. So I think that doing this kind of surgery, €30 or dollars, they means nothing in perspective of spending.
Understood. Thank you for that comment. Jan, do you do the same as Linas does, or?
In our experience, we've got exactly the same protocol as Luca said. We use PV's catheters from Brown, and this is not advertisement.
Thank you.
But everything is exactly as Luca said. I'm keep it very straight how he said, and it really works.
So Luca, the last question to you is that you tend to use all of the different modalities, and one size doesn't fit all. But if you're doing a truncal ablation and you're doing tributaries, why wouldn't you just do thermal ablation now?
Well, I think that if you go to a small restaurant, you normally could just eat a pizza or something like that. But if you go to a referral center, and you normally have the chance to have some choices. And what we normally do is try to make the best plan for that patient about hemodynamics considerations. So, of course, vein diameter, tortuosity, and superficiality, and so on. But also we try to understand the patient needs and try to make a deal normally with the patient by offering the best that we can. So sometimes we don't do total EVLA because we think according to the patient necessity or needs to use something else. But as I showed in our case series, 70% of what we do, or almost 70%, 60% is thermal, and of that, most of the cases is total EVLA.
So I don't have time to ask in depth, but I think you need to help us with your inclusion criteria for the TOTEM and your exclusion criteria so that we understand it. Last question is that fiber that you're using reusable? And can you sterilize it? You've got 20 seconds.
No, our fiber, it's we don't have a secure system that when you disconnect the fiber, that does not allow you to connect it again. So consider that it's not from the instruction for use, but it is possible. We don't do that, but you could consider, because with this specific device, there are some devices in which the connector is one shot, so you cannot use it again. But if you are used to consider that.
We're running out of time, and I appreciate it. And we're here, and I would like to thank Linas and Jan as well. Next week, we're interested in looking at stents and iliofemoral and what we've learned about it. And so we look forward to having, and the last parting shot is Professor Victor Canada is in the background, but he has also had some trial with the so-called porcupine or total laser. So thank you very much. And This will also be found on YouTube, and we'll see you next week. So thank you very much.
Thank you.
Thank you. Bye.
Bye-bye.